Соединенные Штаты Америки. Тема у вас есть, да? Итак, пожалуйста, Лоренцо.
Thank you very much. Again, it's a really great pleasure to be here and actually to follow the presentation that were just done. I'm going to approach this a little bit more on the practical aspects of respiratory management and perioperative obese patients, and in a sense how I approach patients on a daily basis. So some of the slides, a few slides I showed yesterday, but I think they are relevant, so I'm going to show you. And I learned also that just now in Sochi, also obesity is becoming a major issue. So this is why do we talk about obesity, especially in the anesthesia? It's just that obesity in the last 4 decades just blew out of the charts. So this is the chart from 85. There was like a 0 to 10% incidence of obesity. Now we are more than 30% of obesity in the United States. That means more than 100 millions of obese patients in the States. So it's very common in the operating room, therefore, that whatever surgery you perform to have to deal with obesity. And if you look at the prevalence of obesity around the world, it's really increasing throughout, and here in Russia as well, depending on the region where you are, but there is a trend of increase obesity. Now it's about 10-20% of obesity in Russia. So I'm going to give you just a very short, has been already discussed before, so some parts I will skip, but just a short physiology background, and then I will talk about mechanical ventilation in the OR and a few studies that we have done, and then how to win patients from mechanical ventilation. These are clearly obese patients that you can see. It was one of my patients when I was a resident. I was pretty impressed by the dimension of patients that can reach 300 kilos without like 300 kilos and more. So, and to come to the hospital, they really needed to be with a lifter, transported with special ambulances. This is a problem that this is a new report from a group in Alabama, close by, that shows that patients with a super obese, which is called, with a funny name, but it's body mass index more than 50. So it's on average, this report was a 70 of BMI. These patients, 80% of these patients became tracheostomy dependent, and they became actually ventilator dependent, 23%. Why? There are lots of related conditions. We heard before about the poor oxygenation and poor cardiac function of these patients, increase in tracheostomy, and then increase the ventilator dependency. The reason is that the BMI, body mass index, the higher it gets, from 20 to 60, there is a decrease in functional residual capacity and a decrease in total lung capacity. This is explained by just looking at PV curve, so pressure volume curves of the respiratory system. In red, I draw the line in obese patient, which is shifted to the right, shifted down and to the right, which means that the curve is similar to the dotted line, which is the normal line. However, because of the increase in pleural pressure, there is a loss of volume. Therefore, at a normal atmospheric pressure, which is about in normal individuals that are 1 meter and 70 centimeter high, 2 liters of functional residual capacity. In obese patients is about 1.2 if at atmospheric pressure. This translates on a perfusion mismatch, ventilation perfusion mismatch, because if the normal PV curve and the high perfusion is in the lower part of the lungs, there is also it's the area where there is also high ventilation. In the obese, because of the shift of the curve, PV curve down to the right, the closing capacity is lower, is higher, than the ventilation, the level where patient would ventilate, and therefore formation of atelectasis and therefore shunt. Second, there is also increasing in airways resistance, and this is a study showing that the increase in obesity, there is also a decrease in FEV1, and also an increase in resistance, which correlates with the body mass index, and a conductance increase, that is a linear increase with FRC. So in kind of a conclusion of this, just a very short, brief physiological review, the changes are mainly really a decrease in FRC, which causes on one side atelectasis and the other side early airways narrowing. Atelectasis causes pulmonary shunting and dead space, while early airway narrowing causes expiratory flow limitation, which is manifest as asthma-like symptoms. Many of these patients brings also always around bronchodilators, doesn't really help because it's just an expiratory flow limitation, this patient many times. And then dynamic hyperinflation without a PEEP, so an increased work of breathing and total. So I showed, yes, I wish I know about this question about intubation and airways management, because from the literature you have pretty much everything and the opposite of everything. There are people that would strongly, after the study, they strongly believe and support awake intubation for every single patient that is obese in the operating room, other that they want to have a sleep intubation, and other again sleep and paralyzed. The methods very much changes from fiber optic intubation, other they want to have a direct laryngoscopy, and other again with video laryngoscopy. Many times I just would say that it's really, in a sense, in which house do you like? This is just a metaphor, just to say you want to a nice house by itself, or in a skyscraper, or in a countryside. What I would say that these are methods that one also needs to get experience with. So as long this is really, I would say, evidence level 0. This is my experience, so really needs to be taken very humbly. But what I generally do in these patients is really keeping a upright position, because of the supine position causes also airways collapse. 60 degrees, we have like a special beds for these patients. And we allow basically breathing with either a CPAP mask that they bring from home, or just we use our standard mask at 100% of oxygen for 2 minutes at least. We apply standard monitors, but then what I generally do, I use a rapid sequence intubation when I can. I just use a succinate choline, otherwise I use other short-acting if succinate choline is not indicated. We try to perform opioid-sparing techniques to avoid then opioids in the post-operative area. And then in emergency situations, such as CPR or in codes in the emergency, when it's possible, and if it's possible and feasible, we keep the head elevated, but trying to minimizing aspiration. I think the most important part is really to have everything working, which is like a suctioning that allows basically. And then again, for regarding the type of laryngoscope, I think there is lots of studies, one proposing one technique over the other. I think that they are complementary methods, and I use it interchangeably according to, there are some patients that would benefit in more video laryngoscopy, other more direct laryngoscopy. So I don't have one over the other. For mechanical ventilation and for titration of PEEP, I think I really like this study from the Edestierna group, because I think about more than 10 years ago, not even, sorry, what they did was to randomize obese patients in 3 groups, 10 patients per group, and what they did was to ventilate these patients, whether with after induction on just 0 PEEP, or versus a PEEP without, a recruitment maneuver of 55 of pressure, or again doing a recruitment maneuver followed by a PEEP of 10. And so here you see from awake patients after induction, 5 minutes after induction and 20 minutes after induction. As you can see, only recruitment maneuver followed by a PEEP, titrate PEEP, maintain lungs open. In this graph, what it shows is that atelectasis are resolved only when it's applied. In all groups there is some formation of atelectasis after induction, but only recruitment maneuver at 55 of pressure in these particular patients, and application of PEEP maintained returned lungs open. And the PF ratio also improved only in this last group when recruitment maneuver and PEEP titration was applied. So in order to understand really how a PEEP application would be effective, we try to do a combination of methods, and we try to understand what method is best applied, and to do that we did a study in the intensive care unit in patients that were after surgery and they required prolonged periods of intubation for whatever reasons, but they didn't have any lung issues. And so we tried to investigate what methods was best to recruit the lungs of these patients. Specifically, we investigate whether either transpulmonary pressures measurements, which basically by insertion of an esophageal balloon catheter, we measure the absolute values of esophageal pressures, and we maintained PEEP positive and expiratory pressure above the expiration, above esophageal pressure, sorry. While the decremental PEEP titration was measuring best PEEP when elastance was the lowest, which means that the compliance was the highest. What we found was that basically PEEP was equally found, basically the average value was about 21, both either using positive transpulmonary pressure or after titration of a decremental PEEP trial, with or without recruitment maneuver. And however, only after recruitment maneuver, the elastance of the lungs decreased, which means the lungs were more compliant because they were completely recruited. And PF ratio normalized after, actually improved, didn't normalize completely, but improved after recruitment maneuver and PEEP titration. So in conclusion from the first study, we said that the routine PEEP levels were not sufficient in obese patients that we ventilated in our hospital because it was too low, but there was no relationship between the severity of obesity and PEEP requirements. PEEP titration therefore was warranted at the bedside in the ICU, and that no PEEP titration technique is superior. So this is really choices of the ICU team for in our institutions, whether there is some people that are easy, they use it as a transpulmonary pressure, or others that use a PEEP titration by decremental PEEP. Recruitment maneuvers were necessary to maintain physiology of the lungs. And however, the question then was how is it safe in these patients? And because clearly high PEEP, like we did, like up to 20 of PEEP, has some concerns about volotrauma, right heart dysfunction, and electrotrauma. So in order to investigate these possible conditions, we study an animal model of obesity in pigs, and we study really whether our titration may have caused and how to define really at electrotrauma, volotrauma, and right heart function. We monitor right heart function, and this was the protocol of the study. Animals were induced, and we titrate PEEP at baseline. Then we study a 5 of PEEP. Then we applied some external weight on the abdomen to let the esophageal pressure, so pleural pressure, to increase. And then we did an incremental PEEP trial versus a decremental PEEP trial, which means that the incremental PEEP trial was an increase in PEEP in order to maintain transpulmonary pressure positive, 0 plus 2. And the decremental PEEP trial was obtained by elastance of the lungs. So, and we also applied the impedance tomography, which is just a imaging. Can I start the video? Yes. Which is just an imaging, just at the bedside, because in many of these patients we can't, in the ICU, if they are critically ill, of course they cannot be really brought to the CT scan, and sometimes cannot even fit in the CT scanner. So in order to evaluate recruitment of the lungs, and then we also did perfusions analysis, which means that by infusion of 10 cc of hypertonic saline, you can actually follow where blood flow goes into the lungs. So from the right internal jugular you inflate, and you can see, you can look where actually is going to go. So the sequence, you can see, start with to see the right atrium, and then go down in the right ventricle to the pulmonary ileum, down into the right and left lung, and then back to the left atrium. This is great because then you can map and you can do ventilation perfusion imaging as like very gross, so it's not really accurate, but it's at bedside. You can have a very nice tool to look for ventilation perfusion. So what we found was that for in healthy lungs, this was the shape of the curve. As you can see, mostly it's lung atelectasis, so the lung elastance was increased at low and high PEEP. So, and when we applied a weight on the abdomen, the shift, the curve, or the elastance curve just moved to the left, which means that these animals require higher PEEP value. When we look for transpulmonary pressure, we found that the atelectasis formation is actually at the level when transpulmonary pressure becomes negative. So when increase in esophageal pressures or pleural pressures becomes higher than the PEEP level that we set at the ventilator, then the formation of atelectasis are shown on the electric impedance tomography. However, incremental PEEP trial, when we just increase PEEP from whatever level was 5 of PEEP down, going up, didn't really show a good and nice curve of elastance like we saw before by doing the decremental PEEP trial. And I think that's really just by hysteresis of the lungs. When we look at the CT scan, basically what we found was that only the obese decremental PEEP trial recovered all the volume of the lungs. So just and there was no pulmonary vascular resistance increase. So just to conclude this study that was just published, optimal PEEP determined by respiratory system elastance and positive transpulmonary pressure after PEEP decremental, preceded by recruitment maneuver, prevented alveolar collapse and avoid intratidal recruitment decrement and decruitment. And again, I like the last point, which says, unlike an incremental PEEP trial, setting PEEP according to a decremental PEEP trial preceded by a recruitment maneuver does not increase pulmonary vascular resistance. Just to conclude what I do, really, because of course we cannot do all this at the bedside in the OR, but really what I do is try to, after intubation, I do a recruitment maneuver, and to maintain the lowest level of FiO2 I will generally go down to 40% at least to have an assessment if I have the recruitment and shunt. And then I usually generally use pressure control ventilation just because I can continuous monitor volumes and the changes in compliance. If a laparoscopic procedure is required, then I use a volume control ventilation. When I encounter hypoxia, I perform a recruitment maneuver and decremental PEEP trial in the operating room. But I don't do by two steps with 5 centimeters of pressure. And that's, I think it's enough. That's it. I stop here because I think I used too much time. Okay.